is that this gives those of us who are in attendance an opportunity to hear about some of the great work that other people are doing here on campus, to look for potential collaboration opportunities, look for interesting connections, really with the goal here of creating a broader and a more integrated pain research network here at Western. So I'm obviously Dave Walton. Myself and Dave Siminovich are the co-leads of the No Pain Interdisciplinary Initiative, and want to just acknowledge the work that Felix do and Myrna Sellerman also do in the background to keep the initiative rolling along for us. We've got two great speakers. I'm not going to spend a whole lot of time because I'd rather dedicate the time to hearing from them. We've got Naveen Poonai and we've got Anna Zajacova, who are going to be talking to us today about the work that they've been doing. I've just looked at my email to see whose name was listed first, and it looks like it was Anna. Anna, are you ready to go first?
It was a change of plans.
Oh, is that a change of plans? I do
Naveen
not
wants
want
to
to
go
change the
first, so
plans.
I'm fine with that.
Let's keep to the original plan. That means Naveen was going to kick us off then.
Yes.
Understood. That's my fault for going by an informal email.
No,
All
that's
right, Naveen, are you ready to get started?
Yes, I am, and thank you for accommodating, Anna. I'll share my screen now. Okay, great. Can everyone see that?
Yep.
Okay.
Yep.
So thank you, David. So yeah, my name is Naveen Poonai, and I'm a clinical investigator that studies acute pain management, primarily in the ED, but also Um, I study the relationship between acute pain and procedural sedation in the emergency department. Just to start off, I just want to acknowledge that Western University is located on the traditional lands of the Anishinaabe, Haudenosaunee, Lenape, and Attawandaron peoples, on lands connected with the London Township and Sombre Treaties of 1796, and the Dish with One Spoon Covenant. This land continues to be home to diverse indigenous peoples, whom we recognize as contemporary stewards of the land and vital contributors of our society. Most of you know this, but I just wanted to emphasize that I'm going to put this on presenter mode. Um, I hope you can still see it.
Yes.
Okay. Um, Three take-home stats that I like to tell everyone is that pain is the most common reason why children visit the hospital. Probably adults as well. And more than three-quarters of children experience pain in the hospital. Yet pain research accounts for only a quarter of 1% of all health-related research in Canada. If you look at some of the statistics from sick kids, more than half of children admitted to hospital with a painful condition received no analgesia in the ED. And of those that did receive analgesia, 70% of them waited more than an hour and 40% waited more than 2 hours. And compared to adults, kids actually receive significantly fewer doses of analgesia and are often underdosed. What do parents expect? Well, the number one thing they want from their clinicians is to make the correct diagnosis. Number two, they want pain relief for their kids. There's a lot of challenges to managing pain in the opioid era since 2010. And we need to care about this because if we don't manage pain correctly, it can lead to deleterious short and long-term consequences. And the big consequence we really care about is chronic pain. And chronic pain affects about 1 in 5 Canadians. It's roughly the same across the border in the US, costing the healthcare system upwards of 60 to 70 billion dollars annually. So most of the work I do leads to clinical trials. The first thing we do is we have patient partners, primarily with London Health Sciences Family Advisory Committee, but our main patient partner is located all the way in Edmonton, at the Women and Children's Research Institute there. And these individuals are really important to help us identify patient-centered outcomes and what's the feasibility of doing the work that we want to do. The next thing we do is we look for equipoise. Should we do the study? Should we do the trial? What's already out there? What's worked and what hasn't? And the best way to do that is to conduct surveys across the Pediatric Emergency Research Canada network, which is a network of researchers across the 13 research intensive hospitals and childhood care centers in Canada. And we also do medical record reviews, but the primary thing we do are systematic reviews to identify equipoise in a rigorous fashion. And then hopefully down the road, we can launch a clinical trial. But once we get the results, then we need to try to mobilize that knowledge, disseminate it as far and wide as possible. And then we rely on our quality improvement partners and collaborators to put that into practice and measure the outcomes. Patient and community engagement is very important for us for many reasons. Number one, we get a sense of patient perspectives on the design of our study. For example, if we design a trial that enrolls kids from 0 to 18, but the drugs are given or the medications are given, are pills that need to be swallowed, then obviously we don't want to include, anyone that's younger than age 8 or so in the study. And sometimes we may miss this when we design the study. So our patient advisors, let us know about things like this. This is just a very basic example. We also use focus groups, and the focus groups are really nice because when you talk to some patient, a person with lived experience one-on-one, you will get their experience, but you may not get anyone else's. But in a focus group, you can have people bouncing ideas off of each other. And what they do is that these focus groups allow people to recollect their own experiences with the healthcare system and with research. And they build on one another, and you eventually get these themes that emerge, and that really helps us to design our trials. And then we also want to know how best to disseminate the work. What are the channels that we should be using? For example, we have a study going on right now where we did this with teenagers, and we were going to disseminate it using a social media platform, a few social media platforms that we normally use. And then the teenagers said, no, 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 you guys should make a TikTok video. And so, we took the teenagers' advice very seriously, and we're building that right now. So our systematic reviews are basically what we do is we identify the most effective therapies, but we also characterize poorly studied areas of care. And we design our trial to target these areas of care so we can fill an unmet need. The medical record reviews, we were able to identify gaps in care, so we get a sense of what people are doing now for abdominal pain, musculoskeletal pain, and procedural pain. And you get these sort of nuanced insights into practice patterns. For example, we wanted to study midazolam for anxiolysis. We realized that some centers do not use intranasal midazolam, which is the most effective approach. They use oral midazolam. So you can design your trial to respond to clinical needs in a very nuanced ways. And then national surveys are very good because they identify shifting practice patterns from managing pain. We designed one of our trials using intranasal midazolam because we identified a shift in the practice pattern from oral midazolam to intranasal midazolam. And we can also get a sense of new approaches and what some of the barriers and facilitators are for adopting new interventions. And that way, the trial design accurately reflects current practice and logistics within emergency departments. So our clinical trials are basically focused on novel therapies and routes for analgesia and procedural sedation. We also look at digital technology distraction for painful procedures and recovery guidance using mobile apps. So the Ketodex trial is one of the studies that is almost done. And we wanted to know if there was a less invasive, aka intranasal approach to sedating kids, because we know that putting an IV into kids is extremely uncomfortable and distressing for them. And a lot of our regional providers really don't like to do this because they have less experience placing IVs in children, so they send them to tertiary care centers. So we want to be able to empower some of these regional providers to manage children at their own sites. But it's also less discomfort for the child. The ATLAS trial is a study that we're running now, and we want to know if nitrous oxide is effective for laceration repair. So laceration repair is one of the most common procedures that we perform in acute care settings. In fact, I think it is in people under the age of 18. But currently, there is no commonly used or consensus as to the best anxiolytic and analgesic approach for this uncomfortable procedure. So we want to know if nitrous oxide is a good approach for clinicians to use. Does it provide less distress for children? But it also gives nurses a new skill set in caring for children, because often nitrous oxide can be delivered by nurses. So in Canada, we suffer from a lot of regional disparity, as you know. So there's a lot of remote centers in Canada where nurses manage these children. 80% of children are seen outside of tertiary care centers. So we want to be able to give nurses a skill set that allows them to provide anxiolysis and analgesia to children without physician oversight. And we believe it's probably a cost-effective strategy as well. So we always pair some of our clinical trials with health technology assessments or economic analyses so that the people making the decisions, the people purchasing the drugs, the people purchasing the equipment at the hospital can make an informed decision as to whether or not the effects outweigh the costs. The sprain trial is a fun trial that we're doing, looking at a smartphone app to see if it hastens recovery in kids with ankle sprains. So typically with ankle sprains, you can expect to be in pain for anywhere from 72 to 96 hours. But there is a giant subgroup of kids who experience functional limitation for up to 2 weeks. As most of you may know on this call, we not only have an opioid epidemic, but we also have an obesity epidemic in kids. So we're seeing increased rates of obesity across OECD states. These kids sprain their ankles. They try to engage in physical activity for the first time in their lives, which we applaud, but then they're set back because they're at very high risk of ankle sprains. So we want to help these kids to return to function earlier, and we want to provide more consistent discharge instructions. The Virtue trial is another study that we just completed, actually. The last patient was enrolled about a month ago, and we want to know if virtual reality can reduce distress in kids undergoing portacath access. So a portacath is a centrally implanted venous access that sits right under the skin, usually in the left or the right upper chest. And a needle is inserted through the skin into the port to provide primarily things like chemotherapy or to access blood for monitoring kids, primarily with cancer or chronic medical conditions. Currently, this is just done with regional analgesia, but we have to remember that very young kids, that the anxiety also compounds with the pain, and that just promotes procedural distress. So we want to know if VR technology can reduce distress in these kids. And this also empowers our child life specialists to comfort children without physician oversight, to give them an additional tool in their wheelhouse. Precipice is one of the studies that is the closest to or where I'm venturing typically out of my comfort zone in clinical trials, and we've launched a cohort study, a longitudinal 18-year cohort study, to better understand how acute pain, what the risk factors are for children to develop chronic pain. And our primary outcome is to identify the predictors of chronic pain. There'll be some early sub-studies to identify the barriers to pain management, and there'll be some late studies so we can identify risk factors associated with quality, we can identify uh, factors associated with quality of life, vaccine avoidance, needle phobia, and most importantly, mental health. So there's a good correlation between mental health and chronic pain. Hard to know what came first, the chicken or the egg, but hopefully with the longitudinal design of this study, we will be able to identify some of those factors. One of the nice things we're doing with Precipice is that we've not only engaged um, patient partners to identify some of these outcomes, but we've also engaged 5 community partners so that we can identify how best to support people with chronic pain and mental health outcomes in the community once the results become available. So the knowledge to practice gap, yes, we're all aware of this as well. Western, we are a national leader in pediatric research, but unfortunately, it can take up to 17 years for the research we do today to change practice, and that's a whole generation of kids that miss out on our advancements. So we invest heavily in knowledge mobilization. We publish our design, our protocols, our analysis in open access forums. Costs a lot, but it's very good for researchers so they can emulate what we're doing in their own fields. We also have a knowledge visualization specialist that is kindly funded by the Department of Pediatrics and the Children's Health Research Institute through the Children's Health Foundation to produce things like this, text minimize infographics, so that people who are language challenged in language and English proficiency can understand our work. We do national webinars through the Children's Healthcare Canada, Solutions for Kids in Pain, and also the American Academy of Pediatric Landscape series to educate providers. We also run podcasts. The ones we like are the Skeptic's Guide to Emergency Medicine and Emergency Medicine Wrap, which are national podcasts to reach community providers who see the vast majority of kids, and also our social media posts. And we did not forget the TikTok video. Our national KM partners, I've mentioned some of these people before. Translating emergency knowledge for kids basically takes clinical research done at tertiary care centers and allows it to be translated into the language of community providers based on their skill set and what they have in their wheelhouse in these rural centers. So we provide them with bottom line recommendations, knowing that they're very busy. We give them a quick capsule summary. So we've done this for acute pain. We've done this for presenting pain and procedural pain. And we've just completed one for anxiety. Quality improvement's very important to us. And one of the big quality improvement projects that we have launched 2 years ago is the Children's Comfort Promise. So the Comfort Promise is bundled care using these 4 elements. We launched this project at the Children's Hospital a couple of years ago, and it launched in the emergency department and is now being disseminated hospital-wide. And we believe this is a very pivotal period in child health research. We have several new research networks that will help to change how we practice. We have a new research institute at London Health Sciences Center that is supporting our work. And we have a lot of broad support from Western research that we're very excited about. Any questions, please feel free to email me. I'm happy to collaborate. I look forward to collaborations, particularly internal ones.
Thank you so much, Naveen. That was really interesting and very engaging. All right, so I encourage everyone in the audience to think of some questions to ask Naveen. Meanwhile, I will start the discussion. Naveen, I do have a question for you. So you talked a bit about engaging patient partners. I was curious about if you can tell us a little bit more about the process. So you mentioned the Family Advisory Committee, and I'm especially curious about how you engage children in research.
Yeah, so that's a great question. So we do this through a number of ways. So initially we would, when like 10 years ago, when I just started to get my feet wet in clinical trials, we would just identify one person. So what we would do is we would email someone at Lawson, which at Lawson at that point covered LHSC and St. Joe's, and they would put us in touch with someone at the Family Advisory Council, the FAC. So
Okay.
That's a body of LHSC, and what they would do is they would get ask for a one-page summary of your project, and they would send it out to a few people and look for someone who has an interest in your field. But
Yeah.
not only that, they would allow you to present to their committee to get live feedback. You would modify your protocol, and then you would have another chance to speak to them. So that was one of the approaches we did. The other approach we did was we went to research institutes with a lot of experience in patient partners, and we wanted to find specifically persons with lived experience.
Mhm.
So specifically in the discipline or the um, sampling frame or that would be familiar with the protocol that we're using. So, for example, for the sprain trial, we wanted to find someone who may have experienced a lot of ankle sprains in their life because of their physical activity or their sport that they did, things like that. So, and then we would have a one-on-one long-term relationship with this person, and they would come to all of our planning meetings. They would look at our front-facing patient information and review it in detail. So we did this on a sort of a general scale with LHSC's Family Advisory Committee, but then we did this on a more specific basis with a person with lived experience. And then the third facet was the community engagement. So this is really, really important because once you do your work, particularly if it involves mental health, in my experience, sometimes it's hard to target those individuals because they may be in niche groups that you don't know about. So we
Yeah.
identified a few of these community groups that support veterans, that support new immigrants to Canada who have come from conflict zones, children from displaced homes and Indigenous communities to identify who will be best, who will receive the greatest benefit from the work that we're doing. And we say, hey, we're doing the project. We want you to be involved now. We don't want to contact you at the end. We want you to be involved now so that we can shape our work to better support your population.
Yeah. Yeah, I love that. Thank you, Naveen. And I think that's really, really inspiring to all of us here who want to engage with patient partners more in research. So thank you. Dave.
Yeah, thanks, Naveen. Really nice overview of the work, and I'm sure this is just the tip of the iceberg. Um, I know that early on, I had some involvement with some of your planning on the precipice, and I'm really pleased to hear that's moving forward. Could you talk maybe to the group just about the challenges either you've continued to face or have figured out how to overcome in an 18-year cohort study like that?
Yes, that's a very good question. So one of the challenges I think most researchers face is funding. We didn't have that challenge because we applied to one funder, which is the Children's Health Foundation, and competed with two other project teams, and we were the successful team. Thanks a lot to people like you, Dave, and Dwight, and a lot of other people. So funding wasn't really an issue for us now. Certainly, funding will be an issue in the next 2 or 3 years because we're going to run out of money and we're going to start to need to look for additional funds. The initial challenge for us was getting the database set up, actually. So we use RedCap. I know there's many, many other databases out there. We use RedCap because we're the most familiar with it. And we used our institution's instance of RedCap. So normally we use the RedCap at the University of Alberta, but this time, because it's a local study, we wanted to use LHSC's RedCap, or Lawson's RedCap, I should say. So Lawson was very good at providing us support, but we were, a little bit stingy with our money and we could have paid somebody to build the red cap, but instead we decided to train a highly qualified person to make them into an HQP. So that took a very long time. So this study launched, um, I think we enrolled our first patient late last year, and we've enrolled more than 500 patients now into this study. But getting REDCap to be able to send out notifications on a yearly basis to allow the patient to enter their data in by linking it back to a REDCap sheet using their smartphone, that required a lot of work on our part, and we needed a lot of consultation with Lawson's RedCap team. And even now, we're working through a few of the glitches with RedCap because there's a lot of privacy issues. And we have to remember that the system can get hacked. So I've learned a lot about how to put in things like honeypot fields so that bots don't attack the system, and which is real data versus fake data. So things like
Hmm.
that were very challenging. Enrollment has been great. Our consent rate is over 80%, which is pretty good for research. And our 1 year follow-up is more than 90%, because we started last year. So a lot of patients are going through the 1 year follow-up right now.
That's huge and highly impressive. And a slight ulterior motive for asking that question is just again to highlight that for those who might be thinking about trying to launch a large scale or long-term cohort study, it's good to know that there's people like you who have already worked through a lot of, well, I would say a lot, many of the hurdles, and I'm sure there's still others to work through, and that might just give people here on the call an opportunity to perhaps reach out, connect if they have similar challenges. Just knowing that you've already addressed some of those is just good information to have. So thanks for sharing that.
Any questions from the audience? All right. Well, if there are no questions, we will move on to Anna's presentation. So thank you so much, Naveen, for your presentation again. It was really great.
Yeah, it was really, really interesting.
So yeah, I will quickly introduce Dr. Anna Zahakova. Anna is a professor and a graduate chair in sociology here at Western. She's a researcher, and her expertise is in demography, sociology, and social epidemiology of chronic pain from a population health perspective. So, Anna, look forward to your talk.
Awesome. Thank you very much. Let me pop the presenter view as well. Okay, and I trust the slides look okay?
Yes.
Cool, cool. All right. Well, thank you very much for the invitation. Thank you for the introduction. And it was really interesting to hear Naveen's talk. This is going to be, very, very different. So what I want to give people is a little bit of the understanding of what it means to have a population perspective on chronic pain. Although in some sense, I think there's going to be some overlap with what Dave was talking about, right? There's some similarities. So over the 20 minutes, I will just do a brief introduction and then sort of just this, like, what does it mean if a demographer studies chronic pain? I'll give you two examples of our recent work, one published and one analysis in progress. That's just going to be one slide. And I will wrap up because I'm really interested in branching out in new directions. I've never had CIHR funding. I've had other funding. And so I know that I need to start thinking about different things. So I'll end on that. So that's the plan. We do have a big team of amazing collaborators, students, postdocs, and a lot of this is thanks to funding, which is relatively modest. The way we work, we don't need as much funding as a lot of biomedical research, and I'll explain how that works. All right, so a demographer, typically, like me, I'm a professor in the Department of Sociology. Most demographers around the world are in departments of sociology. There are very, very few departments of demography worldwide. In Canada, there's only one or two. My background is in both, so I have a degree, a PhD in both sociology and demography. Again, that is typical, that pairing. Sometimes demographers are economists, and sometimes they're just formal demographers. And my postdocs are also in population centers, one at Austin and then one at Michigan. And there I also was at the Social Epidemiology Center. So that's to say that's sort of that combined sociology, demography, and social epidemiology. And of these, you may not be as familiar with what it means to, what demography is. And demography is a scientific study of population. So primarily your study of mortality, fertility, and migration, but also other demographic processes such as health. And certainly, if I had a label, then the broadest label for somebody like me would be a population health scholar. So not pain scholar as such. And in fact, I have studied other dimensions of population health, such as mortality, disability, and many others. And I really didn't even think about pain. It just was not anywhere within my sort of line of sight until 2018, when a friend came to me and said, we've been talking about collaborating forever and ever. He said, have you thought about chronic pain? And I swear a light bulb went off. Like, just chronic pain is not studied in sociology, and especially not in demography. And so we teamed up with Zach Zimmer and Hannah Grohl-Prokopczyk, who's at University of Buffalo, and we've been sort of working together ever since. We've gotten funding from NIH, so we have an R01 that's finishing up now, and I got a SSHRC Insight grant, and that's been supporting us. So how do I go about my work? This background image is actually my lab. I don't have a lab, I have a computer. So we work sort of in our office on our computers. That's what we do. Our teams are smaller. Within sociology, the training model as such is very different from biomedical training, where students typically pursue their own interests, which we try to steer so it matches ours, but they sort of are in the driver's seat. So I don't have a team of students. I team up with students maybe on particular projects that express joint interest. A demographer may tackle things such as prevalence of chronic pain, less so incidence, but patterns, trends, social determinants, which you can think about social determinants or disparities or inequities. That's very similar bucket of issues. And social consequences. Very little out there on social consequences, but very important. Now, one simple way to think about it is, think about the first sentence in your papers, such as chronic pain affects 20% of adults. That's the type of stuff we do. We provide that sort of broad foundation. But we do a lot more, such as we understand we study how pain is interlinked with mental health. And I remember a presentation here, maybe the prior one, on sort of biomedical mechanisms of the relationship between pain and depression specifically. That's not what we do. We don't go into the biological mechanisms. We provide population understanding of what proportion of people with pain has depression and vice versa, etc. Now, to do this, where do we get our data? By and large, we do not collect them ourselves. In fact, it's extremely rare because we need huge population surveys. So we use large studies, such as the Canadian Community Health Survey, which I'm bringing up here because many of you know it. And it's equivalent in the US, the National Health Interview Survey, which I'm bringing up here because I use it a lot. So surveys like these are huge undertakings. Both of these have annual cross sections of about 50,000 people. So the NHIS has been running since 1957. Canada caught up by 2000, so less than half a century later. But now the CCHS also has even larger, about 65,000 people. Now, it's really important to realize that these are general health surveys. They have to ask about everything under the sun, limitations, disabilities, healthcare utilization, chronic conditions, mental health, et cetera, et cetera. So we only get a little bit on pain. So for instance, the Canadian Community Health Survey, this is from the questionnaire, asks, are you usually free of pain or discomfort? And if we're lucky, like for CCHs we are, we get some follow-ups. Severity, and interference. That's what we have. And so sometimes we may get painful conditions, etc. So some of you may be saying, wait a minute, like, what do you get out of this? Isn't this useless? Like, I don't know who has arthritis. I don't know who has MSK. Probably, who has migraine, who has fibromyalgia. You can't treat all these together. And to that, I'll say, no, you actually can. And we have very nice analogies, such as all-cause mortality, infant mortality rates, hospitalization rates. You think of these outcomes, there are many different causes for somebody to die or causes of death, but we can meaningfully take all-cause mortality and analyze it as a measure of well-being and health in a population. So that's how we think about pain at the level that we work at. And honestly, even if we had the data, the sample sizes from the general population would be too small to analyze something like even fibromyalgia or et cetera. So we typically just look at pain as such. To give you a sampling of what we've recently done, I'm just going to show you only those that we published in pain. And the reason is, again, that everybody knows pain. We also publish in outlets for demographers, for sociologists, for gerontologists, or aging journals, but this will be most familiar. And the reason I'm sort of highlighting these is because there is a sort of as evidence that there's a lot of interest in these types of findings in the pain research world. So just a couple of them. We were looking at a causal analysis of whether pain predicts mortality. We didn't have great measures of pain, and there was a marginal effect. So we're following it up with high impact, more impactful pain, so high impact chronic pain, whether that predicts mortality. Some spatial analyses, in this case, county level for the US, and I'll come back to the spatial analyses. This was a very first study ever that examined pain across sexual minority adults. Some of the results were quite surprising to us. So that was published in Pain. That was a little older. Another spatial analysis. I'll come back to that. This was a paper led by Lauren Harrison out of Stanford that is a call to action to integrate best practice assessments of sexual orientation. So I was on that paper because of the prior paper of sexual minority. And this, I'll just show you one result. This was a massive undertaking. This is a review of reviews that analyzed some 400 reviews of social disparities in pain research over, it's almost 60 years. And the idea was, there's a lot of research on social disparities. What do we mean by social disparities? There are many different dimensions of social disparities. And here we found that, so this orange represents the proportion of studies over the course of 50 or 60 years that focused on sex and gender. And there is, that was a huge priority about 20 years ago, now still a major priority. Race and ethnicity gets quite a bit of attention. But notice green is socioeconomic status. There are huge disparities in pain, and yet it gets so little attention. And look at these blue and purple, which represents cross-country and within-country disparities. Barely any studies out there. So we now understand where there is real unmet need for the studies, and that helps guide next steps that we have. I touched on the spatial analysis. If anybody's interested in this paper, you can just scan the QR code and get to the paper. The reason why we are so interested in spatial analyses is that it gives us hints about macro level factors more than individual level characteristics. So in this paper, for instance, we found there was significantly more pain in the US than in Canada, but we could explain this. This was explained by economic hardship for American adults. Once we controlled for that, then on average, Americans and Canadians reported similar pain levels. But no matter what we did, there were these remaining pain hotspots. They were right here in the deep south in the US, some in the Appalachian areas, and in parts of the West. And there, no matter what we did, we could not explain that, which means there's something above the individual level, such as state context, maybe having to do with pain treatments, but also other things like income inequalities, even things like housing, transportation, policies that you don't think necessarily are closely linked to health, but are in fact sort of deep underlying drivers. So these are sort of the broad range, and I'll just zero in on two examples. First will be one that we just published, also in pain, but a little bit of context. So what we were interested was, so what happened to pain after COVID? But we had actually previously we were the first study that analyzed pain trends in the US, and we found that chronic pain has increased for all groups over the first 2 decades of the 21st century. But there were some indications that at least in some groups, there's sort of leveling off of these increases. So in other words, maybe that rise is stopping or slowing down, and then boom, COVID hit. So the question is, what happened? As COVID started, there were think pieces that were concerned that through various mechanisms, pain would increase during the pandemic. So let's see what happened. Again, here is a QR code if you want to get to the paper. So I'll just show you everything in just one figure. First, in 2019, that's this light gray bar, that prevalence was 20% of chronic pain, which we've all seen that number. It's similar in the US and in Canada. What happened in 2021 during COVID? Has it shot up? No, it didn't. Surprisingly, there was no increase, and for some pain measures, actually decrease in prevalence during COVID. So then after the pandemic, we expected that the prevalence would remain steady, but instead it shot up. It shot up at 4 percentage points. That's a huge increase. I'll put that in context. And that increase was for everybody. It was for men and for women. It was for young and the old. It was for those with more or less education. It surged not just for chronic pain, but also for high impact chronic pain. Same pattern. And it also was the case for by all race and ethnic groups, rurality. Basically, no matter where we looked, we had the same result, this pain surge after the pandemic. And to put it in context, that current, the prevalence of 20% is no longer the case. In the US, currently, that's 24%. That's 10 million more adults with chronic pain than before. So the next question, of course, I'm sure everybody's asking, so COVID, what's the role of COVID? What's the role of long COVID? We've analyzed this, not surprisingly. At the individual level, if somebody reported they had long COVID, their pain prevalence was much, much higher. So long COVID predicted much higher prevalence of pain and high impact chronic pain. But at the population level, there just wasn't enough in a way. So only about 13% of this increase seems to be due to long COVID. And we couldn't find anything else that explained it. Changes in, economic factors, mental conditions, physical conditions, nothing. So we just don't know what happened. The other question that I'm wondering if somebody in the audience is wondering about is, what about in Canada? The question is, we don't know. Not that we don't have data, we have data, but we don't know. The last time that a nationally representative findings were done on pain prevalence trends in Canada was in 2019, and the data only went through 2014. This is the most recent national prevalence estimate. Why is that? Because unfortunately, the data are locked up in research data centers. The data are out there, you paid for it with your taxes, but it's locked up. So I would love to analyze it, but research data centers are physical enclaves, rooms, like one in Social Science Center at Western, we have one. You have to go there. It's a huge rigmarole. So we don't know basically what's happening in Canada. That would be very high priority. Now, a very different, much more sociological exploration, I'll end there, will be on gender expression. This is an analysis in progress. It's a very unusual analysis because it uses data that I actually collected. I told you I don't collect data, which is true, but I actually did collect data. Dave actually and others have helped me put together the survey. We call this the Social Wellbeing and Pain Data Set with 5,000 US adults. These are not pain patients. This is general population. But we were able to put in detailed pain questions. We had lots of interesting things, but one of the questions we asked was about masculinity and femininity. So imagine how you would answer this question. Please place yourself on a scale of masculinity where 0 is not at all masculine and 6 is very masculine. And the same thing for femininity. Those two things are not orthogonal. You can place yourself high on masculinity or high femininity or vice versa. Okay. Why did we do this? Well, because everybody knows that females or women have higher pain prevalence than males or men. Okay, so does that follow then, when we sort of take that out of the realm of biology and think social factors, that masculinity would be associated with lower pain prevalence because men have less pain, and then femininity with higher pain prevalence? Or maybe not, because masculinity is also associated with health behaviors, and so lack of preventive care or lower preventive care that might be associated with higher pain. There's nothing in the literature that would give us something to go on. So we just had to dive into the data. So what did we find? What we found was pretty messy. Very quickly realized we had to separate men and women because masculinity means a fundamentally different thing for men than for women. Then we realized that masculinity and femininity interact in really complex ways, less so for women, but for men, sort of when you interact these two levels, you just get these crazy, crazy patterns. So we wrestled with these data, but the one way that we are seeing what's happening is that it's gender concordance. So women who were high on femininity and low on masculinity, and men who were high on masculinity and low on femininity seem to report the lowest pain. And everybody else has various degrees of higher. So these people had the lowest pain. And so we are going to dig deeper into how much more we can push this. There's a lot more in the data, but just to give you a sampling of much more sociologically oriented research. And to wrap up, so we are using these swab data for many other research questions including one that's measurement dynamics of pain to better understand reporting of pain in the survey. So, for instance, many of these large surveys ask the question, are you often troubled with pain? Boom, that's all we know about these people. What does it mean? Are you often troubled with pain? We can answer that. We now know that about 95% of people who say that have in fact chronic pain with a duration more than 3 months. We know where, etc. So we can characterize pain. These are just some of the questions that we can answer. Now, on my wish list is that question that I already hinted at, the pain after pandemic in Canada. If I can entice a graduate student to help me with the RDC work. And then I'm here because I am interested, like I said, in branching out towards CIHR funding. And I am interested in ideas for collaboration. Basically, this is what I do and how I think about it. What are some unmet data needs that a demographic perspective can answer that that you might need or you might be interested in, or ideas for collaboration? And I'll end there. Thank you very much.
Thank you so much, Anna. That was really thought-provoking and interesting. Okay. Any questions from the audience? Please don't be shy. Yeah, go ahead.
Thank you very much for this presentation. It's really interesting. It sort of mirrors, I'm a psychologist, that sort of mirrors questions, why are rates of depression, for example, higher in women? And I was wondering if there's any research on the impact of sort of the domestic burden on women and increased chronic illness.
Oh, that's an amazing question.
Yeah.
So within demography, not so much. I think there is research in psychology, a lot of it qualitative research. So I don't know it very well. All I do is quantitative about gender roles. I don't know that it's specific to sort of the second shift. It's more broadly on gender roles, and also typically focused on interactions within the healthcare system. So things about femininity and gender, female gender role within the interaction with healthcare providers. But that would be really, really interesting to look at. I'm not aware of that. It may exist out there a little bit, but probably not a big untapped literature.
I can offer a quick insight on that. It's something one of my colleagues, Joy McDermott, has tried to explore, Heather. And part of the issue is that the data are just, I mean, they're not good, and it's really difficult to measure. So I know they're trying to actually create sort of basically a measurement scale of something along the line of domestic roles or domestic duties, and it's hard. How much of the lawn mowing do you do? Well, is that a reasonable question? That's on scale, but what if you live in an apartment building? Like there's so many ways to parse that. So it's been difficult research to do.
20-something years ago, I tried to do research using the who does what scale, and nobody knew how to fill it out.
Yeah, it's been really hard.
Yeah.
There's actually really fascinating research when the same questions are posed to spouses, husbands and wives, and there's not a lot of agreement.
Ibo, go ahead.
Yes, hi, thanks. Great presentations from both, very insightful. My question is, you mentioned how research in demography and sociology are done very differently than like biomedical research. My question for you would be, if we were to merge, how do we bridge this gap, or what's missing, or how can one benefit from another in a more collaborative manner rather than some people doing the wrong thing and other people doing the wrong thing?
Oh, that's a brilliant question. So I don't have a ready answer. A better answer than that is one thing is to think about it as sort of a ladder where in order for for funding to be available, we need to establish something is a problem. So that's something that we can do. But there's actually more and more data sources like the UK Biobank and many other biobanks where at least some biomedical information is included, and some of the large-scale population studies can draw on it, like in GWAS studies or in sort of at least using some biomarkers. However, I know this research from my perspective. So from a clinician's perspective, maybe this is quite lacking in terms of what the data collect, but that would be certainly something that's being done more and more, and is probably one way to merge the two, where you have still a population perspective, but you have at least some indication of what goes under the skin, if you will.
Thank you.
Go ahead, Sama.
Yeah, thank you so much for the presentation. I just have a very quick question. I'm just interested in these surveys. How was pain identified or defined? Sorry. How do you think people perceive the question about pain or the term pain?
May I just clarify that I understand the question? Are you asking about how do we know what people are telling us effectively?
Yeah, I'm just wondering, like, how did they understand the term pain?
How do they understand the term pain? Brilliant question. People do seem to understand it very well as physical pain. In the SWAP survey, we randomized. There's a bunch of randomization in that survey. We randomized the intro to the pain question, and we asked one half the people, we want to ask about your physical health, and the other one we want to ask about your health. Is there going to be a difference in how people react to the pain question? It was stupid if people did, or all of the data would have been, but there was absolutely no difference. So if you're wondering about whether people are responding to as emotional pain, we don't think so. In follow-ups, we also asked people to tell us more about their pain. It was all about physical pain. Out of 5,000 people, I think we only had handful, 2 or 3 people who said something about emotional pain. So we believe that people understand this very sort of as physical pain, if that's what you were wondering about.
So do you think that people may, like, when do they start defining or saying that we have pain? Is it like according to numerical scale, they start saying we have pain after 4 or 5 or 10? Do you think they define pain once they feel they need to seek medical care? Do you think that they define pain once it has an impact on their daily life? That's where I'm confused, because I had previous discussions, and some people actually say, well, if you ask anybody, do you have pain? They will say yes. So considering the limitations of self-reporting, I'm just wondering, and how can we actually ask the question about pain, and what does it, like, trying to capture what we are we trying to capture clinical status or a diagnosis? What exactly was the purpose in these surveys?
Awesome question. I know that we're out of time, so I'll try. So I totally understand as people need to peel off, but you're asking it at like the $1 million question too. So to make it so, note everybody will tell us they have pain. In fact, as I said, when I said the pain prevalence surge, it surged to 24%. 74% of people said they do not have pain. Now, that's the way that we ask questions is very important, and actually that SWAP survey is meant specifically. We developed it with the exact purpose of being able to create crosswalks between the way that CCHS, NHIS, and other surveys ask the question, because they do it differently. The most typical way is the following question. Over the past 3 months, or during the past 3 months, would you say you had pain never, some days, most days, or every day? And people who said most days or every days are classified as having chronic pain. And then you can also go from there towards high impact chronic pain. People do answer this question very meaningfully. In our SWAP survey, we also have the numerical pain scale. There isn't a threshold, but there is a very high correlation. So people who have frequent pain also are much more likely to give us higher NPS scale measure, and vice versa. So people respond to this quite meaningfully. People who say they have pain more frequently also have more pain, are more limited, have pain in more pain sites, etc., etc. So now so there are many ways to go, right? Like then how do you sort of assess the reporting to some underlying true measure of pain, which we all would love to get at, but that's impossible. Pain is whatever the experiencing person says it is, right? By definition. And in terms of the measures, the pain measures in surveys, that's what we can tackle. How we not so much ask the question the best way possible, but at least how do we make the questions uniform so we can compare prevalences and patterns across surveys. So happy to chat more, but I'm very aware that many people have to go, so I'll stop here.
Thank you so much. Thank you.
Thank you so much, Anna. That was wonderful. And thank you everybody for asking questions. That was it was really nice to see how engaged everybody is.
Thanks, everyone.
Thank you so
Great session. I know.
much.
Bye. Thank you so much, Anna, again.